I'm Dr. Susanna Vanderpool. I'm a neonatal and pediatric clinical pharmacist, and today we're going to be talking about neonatal late-onset sepsis. So, sepsis is divided into early and late onset based on postnatal age at onset of symptoms. Cutoff points have historically varied from 48 hours to 7 days. Today, the most common cutoff point is 72 hours. And so, late onset sepsis is sepsis occurring in a neonate that's greater than 72 hours of life. So pathogens that cause late onset sepsis are nosocomial pathogens. So the most common is coagulase negative staph. This makes up about half of cases. The second most common is Staph aureus, specifically MSSA. This makes up 10%. E. coli is the next most common, making up about 5%, followed by Klebsiella pneumoniae, and then even less common is Group B streptococcus, Enterococcus species, and Pseudomonas species. Adverse outcomes associated with late onset sepsis can be really severe and include cerebral palsy and death. Similar significant adverse outcomes that we see with early onset sepsis. But unfortunately, late onset sepsis is much more common. The incidence is about 6 to 7 times higher than with early onset sepsis. So it's really important to be able to identify risk factors associated with late onset sepsis to help us assess the risk as well as potentially the organisms that might be causing late onset sepsis, because there's a lot of different organisms that we need to be aware of. So some risk factors would be obviously low gestational age, right? Increased length of NICU stay, more exposure to things like central lines, exposure to TPN, especially for prolonged periods of time, also mechanical ventilation, and antibiotic exposure. This is a big one. So, diagnosis of neonatal late onset sepsis is really challenging because signs and symptoms are very non-specific. So, the most important thing is to get at least 1 full ml of blood for your blood culture. The incidence of falsely negative blood cultures is pretty high, especially when only half an ml of blood is obtained. We also want to get a CBC with a differential. An I to T ratio greater than 20% is suggestive of sepsis. For the CBC, we mainly look at the white blood cell count, which can be high or low in sepsis. We definitely want to get a lumbar puncture if this blood culture comes back positive. It's not required for diagnosis otherwise, but definitely if the blood culture comes back positive, you would want to get it then. We also want to get a urine culture and urine analysis to help us with diagnosis. And then finally is CRP, or C-reactive protein, or procalcitonin. So both of these can be used as a marker of appropriate therapy after initiating antibiotics. They are sometimes used as a diagnostic tool, although there are some caveats. So for CRP, it can take a little bit of time for the CRP to rise in the setting of sepsis. So just because the CRP doesn't look super elevated doesn't mean there's not sepsis. Procalcitonin is very sensitive after 72 hours of life, and it does rise faster in the setting of clinical sepsis. So that makes it an appealing diagnostic tool. But we still don't have a lot of information about what level we should be looking at for diagnosis. So some recommends greater than 0.5. Some literature says just greater than 2. So a lot of variability. So we can get a procalcitonin, but as a diagnostic tool, not as clear, but definitely as a marker of appropriate therapy. There are many possible empiric regimens for late onset sepsis, so let's break down each one. Historically, ampicillin plus gentamicin was used. We know it's broad spectrum, we're comfortable with it, we use it for early onset sepsis. But the problem with ampicillin and gentamicin is that it really lacks coagulase negative staph coverage as well as MSSA coverage. And remember, these are the 2 most common pathogens in late onset sepsis. So vancomycin and gentamicin is another option. This combination has excellent coagulase negative staph coverage as well as excellent MSSA coverage. But the issue with this regimen is that both of these drugs are very nephrotoxic as well as ototoxic. And so using them together, you have an even higher risk of these toxicities. The other problem with this regimen is that it's very broad spectrum. So with use, you increase risk of gram-positive organisms that are vancomycin resistant. And then you also have the issue of an increased risk of gram-negative sepsis later on in life. So my recommendation is to utilize this regimen only in neonates who have a history of MRSA colonization or infection. The third option is nafcillin or oxacillin plus gentamicin. So this regimen does not have good coagulase negative staph coverage. About 75% of isolates will be nafcillin and oxacillin resistant. It does have great coverage for MSSA. So the thought here is that MSSA is the more fulminant pathogen, and it might be worth it to forego vancomycin empiric use. And so there have actually been studies comparing vancomycin plus gentamicin with nafcillin or oxacillin plus gentamicin, and then narrowing. So you basically start with nafcillin or oxacillin, and then if the culture comes back with coagulase negative staph, then you would switch your therapy to vancomycin. So this decreases vancomycin utilization pretty significantly. And outcomes, actually, pretty interestingly, are no different between the two empiric regimens for coagulase negative staph sepsis. So there's no difference in mortality, no difference in duration of bacteremia, as well as no difference in recurrence at 14 days. So you could consider using this empiric regimen, which would avoid the nephro and ototoxicity, as well as the broad spectrum exposure to vancomycin. So that's our three options for our regimens. So what about gentamicin? When would we replace gentamicin with something else? So there are essentially three reasons why you would replace gentamicin with a cephalosporin. My preferred cephalosporin is cefepime. I have one video that reviews cephalosporins generally, and then I have another video that goes over ceftriaxone's relative contraindication in neonates. So please watch those videos if you'd like to learn more about why I prefer cefepime in neonates when a cephalosporin is needed. So the three indications would be meningitis. Gentamicin doesn't penetrate the CNS well, so cefepime will. So that's one reason. AKI, acute kidney injury. Gentamicin is inherently nephrotoxic. And then the final reason is for escalation of therapy. So your neonate is on one of these regimens, not improving. Something that you can do is escalate your gentamicin to a cephalosporin. We want to avoid cephalosporin overuse because it's associated with many risks, including candida infection, antibiotic resistance, anemia, and mortality. So duration of therapy is essentially dictated by three scenarios. The first scenario is a rule-out sepsis, meaning that we initiate empiric antibiotics, but once the bug culture doesn't grow out at that 36 to 48-hour mark, we can say, okay, we don't really suspect sepsis anymore, the bug culture is negative, and so we can safely discontinue antibiotics. For late-onset sepsis, I usually go with 48 hours. Coagulase negative staph takes about 30 hours to grow out. Sometimes the lab in the hospitals that you might work at don't update their cultures every 12 hours. It might be daily. So if it grows at around the 30-hour mark, you might miss that window if you discontinue at 36 hours. So 48 hours is a good rule of thumb here. Presumed sepsis is when the culture doesn't grow out, but you still have some conviction that the neonate has sepsis. So we usually treat this for 7 days. Culture-proven sepsis also obviously means that the culture did come back positive, and so we're going to treat for a full course. Depending on the organism, that will be 7 to 14 days. If you suspect or you have confirmed meningitis, you actually will treat for even longer, at least 14 to 21 days. And don't forget, depending on what antibiotics you're using, you would also need to increase your dose of ampicillin, increase your goal vancomycin troughs to 15 to 20, or you could switch to linezolid for better CNS penetration. And you would also want to increase your nafcillin and oxacillin dose for better CNS penetration. dependent upon your duration of therapy, you also need to perform therapeutic drug monitoring. So for gentamicin, you should do therapeutic drug monitoring for any duration greater than 48 hours. I have a video on this that goes over how to do it properly, so please check that out. Vancomycin, you should do trough monitoring right away, no matter what duration you're planning for. You can aim for a trough goal of 10 to 15 if you are suspecting meningitis and you want to continue using vancomycin, or if you're suspecting MRSA, then you should have a goal of 15 to 20. Thank you so much for watching. Please let me know in the comments what topic you'd like me to cover next, and if you liked this video, please subscribe.